Good morning, and welcome to Ask Dr. Murphy, This Week in Public Health. I hope everyone is doing well today. My name is Katie Berg. I'm a research study coordinator with the Havey Institute, and I'd like to welcome and introduce Dr. Robert Murphy. Dr. Murphy, how are you this morning?
Doing well, thank you.
Dr. Robert Murphy is the executive director of the Havey Institute for Global Health and the John Philip Fair Professor of Infectious Diseases here at Northwestern's Feinberg School of Medicine. Today, Dr. Murphy will be addressing several viewer submitted questions, the latest headlines through today, April 17th. We welcome you to continue submitting any questions or comments down below. Starting today with a submitted question. A viewer asks, can you remind me when a person over 65 should get their annual COVID vaccine?
Well, it really depends. Pretty much everybody that's at risk for COVID, which means you have any underlying disease or you're just happen to be older, um, should get at least once per year. And the vaccine like the flu vaccine, it gets readjusted every year to make itself work better against the circulating strains, which are constantly changing. So those new vaccines come out in September or October. So pretty much everybody should take that. However, if you've got any kind of underlying immunocompromised condition, you should take another one in 6 months if you really want to be protected against COVID and all the problems associated with COVID. So it depends on your background.
And speaking of some of the things that can come from COVID infection, there was just a study from Sweden looking at long COVID patients and the risk of heart disease. Can you break it down for us?
Yeah, so Sweden has a very centralized medical system and a database of it. Everybody's basically in it, like our Medicare system. Okay. And this is a study that came out of the Karolinska Institute, which is the top like medical research institute in Sweden, in Stockholm. And they looked at cardiovascular events in people that had long COVID. So not everybody gets long COVID. So it's maybe 7%. We don't even really know how many. But anyway, they looked at 1.2 million individuals in their health registry database. About 9,000 were identified that had long COVID. Okay. Two-thirds of them were women, which we know more women have long COVID than men. We don't know why. Patients were followed for 4 years, and the researchers found that among women, 18.2% of the long COVID patients had a cardiovascular event. And that was compared to only 8.4% of women without. So that's, more than twice as likely if they had long COVID to have a cardiovascular event. If you look at the men in the study, now 1/3 of the patients were men, 20.6% of long COVID patients had a cardiovascular event. That was compared to 11.1% of those without. So basically twice as many, almost twice as many. So this is we knew COVID always causes some kind of heart problems. So we know, and even in young kids, they can get pericarditis. So we know it has some kind of action against the heart. And this is some very good data, at least in the long COVID patients, that there's really a much higher risk of cardiac disease. So cardiac disease is the number one killer in the world. And so, it's just important to realize that that is yet another risk factor for heart disease.
And speaking of heart disease, there was another study by the European CDC looking at the flu vaccine and cardiovascular events. Can you bring us that data as well?
Well, having flu can also have negative consequences later. And so this is a European Center for Disease Prevention and Control, sort of like their version of our CDC or how our CDC used to be. And they looked at 1,221 adults over 40, and they found that hospital admissions for heart attack and stroke together were 3.5 times more likely in the week following a confirmed influenza infection, with a heart attack risk particularly elevated 4.7 times greater. So we're seeing with flu, you have the same like increase in heart problems. And this is just after acute influenza. The other study on the COVID was in people with long COVID. Now, notably, among those that had received the season's flu vaccine, the excess cardiovascular risk was half that of the unvaccinated individuals. I mean, this is pretty dramatic that you could cut your cardiac event rate, heart attack rate by 50% just by taking the flu vaccine. And this is just adults over 40 that they've been able to study. So it's just, these viral infections have all these other secondary consequences that you don't want to have. So it's just important to know that these viral infections can cause a lot of other problems in other places in the body.
Absolutely. The vaccines are helping us more than we even know. And that brings us to our second question, which is how many years is the RSV vaccine effective for seniors?
Well, we know that over time, the RSV vaccine, the antibody effect wanes. It goes down. We're like in the third season from when the vaccine came out. There's still no official recommendation change. And remember now, the RSV vaccine was approved for those 60 years and older in May of 2023, and that got extended to those 50 and over who had some kind of increased risk. So basically, any underlying medical problem, even hypertension and the like, and everybody 75 and older, and pregnant women in their third trimester, uh, where the vaccine would prevent the woman from getting sick during pregnancy, but also the antibodies that the woman would make from the vaccine will protect the baby. Um,
Mhm.
and that's, RSV is a big cause of young children getting admitted to the hospital and being quite ill. So there is no official change. They do know that the single dose is approximately 63% effective in preventing severe disease and 51% effective against infection, even after 3 years. So it's still working. So we don't know when the booster thing will come off. Same thing happened with pneumonia vaccines. Nobody knew really how often you had to get it, and that's all been worked out also as well.
Mhm.
Take a while. We have
So
to
the
look
CDC
at the
has
data.
not changed. Oh, excuse me there.
Mhm.
The CDC has not changed their page that the vaccine is effective for 2 years. However, Dr. Murphy did reference a study from The Lancet there that has found at least that much protection through 3 years. So we will
Mhm.
wait and see on that one. But
Right.
there is more RSV news, and that it's still spreading, prompting states to extend the immunization period for that other group you mentioned who is highly at risk. Can you
Yeah.
break it down
So
for us?
from the winter respiratory infection season should be pretty much over. And, so flu, COVID, and RSV should all be coming down. And what they found the last week of March, the RSV numbers were actually higher than the week before. So they've extended the period of time that we're watching for RSV because it looks like it's hanging around a little bit longer than expected. Remember, RSV is the leading cause of infant hospitalization in the United States, so we have to be really, really careful. There is a monoclonal antibody also that can be used to prevent infection in the children, besides the vaccination, like we mentioned, to the mother in the third trimester. This is for kids under 2 years of age.
Yes, very important to know. And we have another question, this time about the measles, which we know have been off the charts this year. The viewer asks, they're an adult who was raised by anti vax parents and have never had measles or the vaccine. Their neurologist has indicated they can't take live vaccines and perhaps that masks are ineffective at preventing measles spread specifically. Is there anything they can do? And is there the potential of an mRNA measles vaccine in the future?
Well, it's very difficult to make a recommendation here without knowing really more about the person. I mean, a neurologist has said you can't take any live vaccine, and measles is a live attenuated vaccine. Now, I do know that we give the measles vaccine to kids with HIV, and there doesn't seem to be any significant problem. It is an attenuated vaccine. It's kind of damaged, so it's not supposed to cause a problem. But I can't really make a formal recommendation without really knowing more. But you could always get another opinion, perhaps from an infectious disease or vaccine expert, to see what they think. Now, it's unfortunate because measles is so infectious, and if this person is immunocompromised, which sounds like they might be, measles would be really devastating. So it's always a trade-off, the vaccine or getting the disease. Remember, measles is about the most contagious thing that we know. Um, Using a mask is ineffective. I'm not sure that's really true. We know that masks are effective. They're not 100%, but they are effective. So I don't think that's really true, but there's no, you know, they're not 100% effective. Okay. Now, the good news here is there is an mRNA vaccine, which is, a manufactured vaccine that is not live and attenuated. And that was developed in New Zealand at the University of Auckland. And the data that have come out of the study of that was that it was quite effective after 2 doses. So I don't know where that sits in the whole worldwide approval process, but it looks like in the relatively near future, it should become available. This mRNA technology is really incredible. And you can really sort of use that technology to develop all sorts of vaccines and immunotherapies. So it's you know that's likely to come in the near future, but we don't. I don't know. Nobody knows when.
Mhm. We will keep our eye out for news on that. But you touched on HIV patients there, and that is a great segue to an unfortunate story that the US is officially ending lots of different funding for HIV and malaria. Can you bring us the details?
Yeah, this is, the USAID being torn apart, left a lot of people with chronic HIV who have to take medicines daily, or the HIV comes back and could kill them. That was very abruptly stopped and was a catastrophe. The estimates are some 4 to 9 million people could die because of that rapid action. So here, another part of the U.S. Foreign aid program was um, the Global Health Supply Chain Program, which delivered over $5 billion of HIV and malaria products to 90 countries from 2016 to 2024. This week, the U.S. State Department officials directed staff from 17 African countries and Haiti to cease all program implementation by May 30th. That's like a little over a month away. Several sources have warned that the rush timeline is likely to put dangerous gaps in life-saving supplies for these diseases. And internal emails that were leaked said immediate risk to service continuity if the transition is rushed is incomplete or incomplete. It's no clear reason why this is being done so rapidly. I mean, if you're going to stop a life-saving program with medication, you could wind it down over a year or 2 years, and try to find some other donor agencies to pick up the slack, but to just say, oh, by May 30th, we're done. Very irresponsible.
Very irresponsible and sad, frankly. But our last story today is in a different vein. It's about Epstein-Barr and a connection with mono and MS. Can you tell us about it?
So Epstein-Barr virus, one of these herpes viruses that is more commonly, almost everybody gets it, by the way. over 90% of people will get it at some point. Most people don't even know they had it. However, if you sort of get it later in like your adolescence or early 20s, a young adult period, many of those people get what's always been referred to as mononucleosis or mono. I'm sure everybody's heard of that. Oh, they have mono, small lymph glands and whatever. And it's self-limited. People feel sick for it could be days to weeks or even months, but then everybody recovers. Well, a study published in the journal Neurology Open Access by the Mayo Clinic, highly reputable group, of course. They said that the people that developed that clinical mononucleosis, which is not everybody with Epstein-Barr, but that segment I just described, were 3 times more likely to develop multiple sclerosis later in life. Now, that's an association. It's not a direct causality, but I've never heard that it was that dramatic increase in multiple sclerosis. So it's just the more we look at these things and study them, the more we learn, and hopefully it'll help us better treat them in the future.
Absolutely. It is a staggering finding. And I would like to thank you, Dr. Murphy, for your time and expertise, answering our viewer submitted questions, and bringing us all of the important information on the latest public health headlines. So thank you.
Thank you, Katie.
And thank you all for joining us for Ask Dr. Murphy this week in public health and for submitting your questions. We look forward to seeing you next week. And of course, if any questions or comments come up, please feel free to leave them down below or at any of our social media, including Dr. Murphy's new Substack. We'll see you next week.